Hi, you guys. Thank you for joining me again on Ask the Egg Whisperer. I know you missed me. Don't worry. I'm going to keep coming back until I've answered each and every one of your questions. Have you ever met someone who's this annoyingly positive? I know. You probably haven't. I literally wake up each day and I'm like, what can I do today to help each and every fertility patient that needs my help? It's really as simple as that. And I don't go to sleep until I feel like I've done the very best job for each person that I've met in that day and interacted with. Yep. That's me. And for now, I don't see that changing. It's almost like a superpower and sometimes a curse. Ask my husband. I wonder if he's watching. In fact, I came home last night and he was soaking in a bubble bath drinking scotch. Maybe not the scotch part, but he was watching the Instagram live. And I was talking about, please don't get in the hot tub, no scotch for you. He actually thought that those were pretty good suggestions. And I'm actually going to give a shout out to my husband and say, I freaking adore you. Thank you for allowing me to do what I do and help people. And please start the bubble bath for me and have some scotch next to the edge of the tub. Okay, guys, I'm going to start answering your questions right now. Here we go. This question is from Lena. Hi, Dr. Aimee. I just found out that I have a chromosomal inversion and I'm currently 7.5 weeks pregnant. This makes me a lot more stressed about my current pregnancy. I had an ultrasound at 7 weeks and the baby was measuring 6 weeks, 6 days, but the gestational sac was measuring 7 weeks, 5 days. I tried to do some research, but didn't find anything about a gestational sac growing much faster than the baby. Is that fairly normal or any cause for concern? Okay, Lena, I have a fun joke for you. We like big sacs. We really do. Big sacs are good. And I wish I had some better line than that. But the reality is, it looks like the embryo is the exact size that it needs to be. 6 weeks, 6 days, 7 weeks, I mean, that's the same. A big sac, that's never a problem that you need to worry about in the first trimester. So you're totally good. And then your next question is, also I have a 2 centimeter subchorionic hematoma. My doctor said I shouldn't worry, but is that a potential issue as well? Let me tell you, subchorionic hematomas are so common. That's a really scary word with lots of syllables, and anything that says hematoma to me, wow, it would give me anxiety if I wasn't a fertility doctor. But the reality is they're a lot more common than people think. And it doesn't mean you're going to miscarry. It doesn't mean you're going to see blood anytime soon. To me, it just means, you know what, come on back in a week or two and let's take a look again. And then sometimes if it looks like it might be large or you're spotting, I give you precautions and I tell you things to do and don't do. But for the most part, I think you're going to be just fine. And that chromosomal inversion, it may not be clinically significant. So do talk to a genetic counselor. A lot of inversions are not clinically significant. So I hope, Lena, that my answer is going to help you. This next question is from Laura. Laura is saying, hi, Dr. Aimee, I'm 35. Husband's 36, and we've been trying for our second child for 9 months. Got pregnant quickly with our first. After 6 months of trying, tracking ovulation with OPKs, BBT, CM, and having spotting before my period around 10 days, 11 days post-ovulation, I did some testing with my OBGYN just to be proactive, and I found out that my AMH was 0.92. Everything else is normal. But because of my AMH, I was referred to an REI. That's me, you guys. One of my people. They didn't retest my AMH, but they tested everything else again. FSH 10.9, vitamin D 24, AFC 8. I'm taking Theralogics, Ovavite, and vitamin D supplement now. My HSG was normal, semen analysis was normal, except for low morphology. Now we need to decide on next steps. We're not sure if we want 1 or 2 more kids. So we're considering IVF to freeze an embryo given my AMH and because we have good insurance. Are we crazy to think about going straight to IVF before trying IUI or waiting a bit longer to see if we conceive naturally? Anything else we should consider? Thank you. So Laura, I think just looking at everything, you are someone who probably still has a pretty good chance to get pregnant naturally. You've been trying 9 months. Your hormone levels are good. Sperm is just fine. Maybe some slight low morphology. Maybe give it a few months. However, if there's a chance that you would be okay with having more embryos frozen than you would need for the future, maybe take advantage of doing a fertility preservation procedure like IVF to secure options for yourself in the future. But I think long and hard with my patients, especially when you already have one baby, about doing IVF and how it's going to make you feel if you had leftover embryos. I think that sometimes we don't think through that part of IVF enough for people before they start. Because I imagine most people say, and my patients, when they come here, I'm like, how many kids do you want? They look at me like I have 3 heads. And they say like, just one if we're lucky. And, my heart breaks when I hear that. But a lot of times, not a lot of times, but depending on your age, many times you might actually get more embryos than you need. So if in the next 3 months at that 1 year mark, you can set your clock and just say at what point enough's enough, go right to IVF and do it. But I don't think that your eggs are going to go away overnight. I think it's okay. Get through the holidays, maybe in January or February, explore IVF at that point. And take your CoQ10, and it sounds like you are. For those of you who don't know, she's taking Ovavite, and that's from Theralogics. And you guys can use my PRC code, and surprise, surprise, the code is Tushy, all caps, TUSHY. This next question is from Kate. Kate says, hi, Dr. Aimee, thank you for everything you do. My question is about IVF with poor response and low AMH. I've had 4 failed IUIs, 2 rounds of IVF. The second round gave us 3 eggs, 1 blast. That was normal, but my PGS transfer, my FET, did not work. My AMH is 0.4. I'm 37 years old. We tried estrogen priming, no birth control pills thanks to your advice, Ganirelix 3 days prior to cycle day 1, then Gonal-F 300, 150 Menopur, increased to 150 Menopur on day 5. But we're only seeing 2 follicles growing, 1 on each side, a 10 and a 9. My question is, seeing such poor response, would you go ahead with an egg retrieval for just 2? I'm 37 and given my low AMH, I feel like I'm running out of time and desperate, but I don't know if we should do egg retrievals with such low numbers. I'm taking CoQ10, Ovavite. What else can I do? Okay, Kate, here's the deal. Your AMH is 0.4. What that tells me is the mature egg rate is going to be around, 2 to 4. Some cycles will be 2, some cycles will be 4, and maybe you're going to see a cycle of 5 at some point. So my thing is this, you already have that 1 embryo. Actually, that's not true. You had that 1 embryo, but you transferred it and it didn't work. So the question you should be asking your doctor is, why is my response so poor this cycle? And the answer is in the question that you asked me. It is very possible, and talk to your doctor about this, that taking so much Ganirelix for 3 days before you started stim was too much for your body. It's almost like taking birth control pills, right? So that might not have been good for you. If you were a patient of mine, I would say, look, why do anything different? Let's do the exact same thing that you did to get that first blast, and then maybe do it again. I wouldn't have changed anything. And again, it's hard for me to say because I'm not your doctor and I'm just giving you ideas and questions to ask, but certainly ask your doctor, hey, can we go back to that first protocol? I think that's a good idea. And then the other thing is this, implantation testing, please, okay? So make sure you've talked to your doctor about doing the ERA, Receptiva, look at the cavity preconception labs, look at all of that stuff. And since you're already on CoQ10, the only other thing that I would add is NAD. Try taking that and see if it's going to help your egg quality, as well as HGH. That's one thing you didn't mention that your doctor might have added to your protocol. If they didn't, maybe ask them about that and see if they would consider adding that for you. This next question is from Alicia. Alicia says, hi, Dr. Aimee. Your info has been so valuable to me. I'm 33, trying to conceive for 4 years, 2 months, 1 pregnancy with Clomid, and it ended in a miscarriage at 6 weeks. I'm sorry, Alicia. I've done all the things, just finished my first IVF cycle, and I had 15 eggs. 14 were mature, that is awesome, 13 fertilized, and 8 embryos, all good quality. They were sent for PGT testing. I'm trying to decide if I should do an ERA or not. My doctor seemed less than thrilled by the idea, stating that he hasn't experienced significant increase in live birth rates, but ultimately, it's my choice. Okay, so this is the thing. Significant? What is significant? I mean, for me, helping just one person with a live birth, for me, is significant. So I digress. Financially, it's a big decision, as they quoted us $3,000 for it. But if it really increases chances of live birth rates, then I want to do it. I don't want to waste time and money if there isn't a significant benefit. My BMI is 36, and I've heard you mention higher BMI rates can affect or can benefit from ERA in the past on your show. What do you think? Also, I have endometriosis and had a laparoscopy 3 years ago. When should I start NAC supplements? Okay, Alicia, let's break it down. Diagnosis before treatment. Let's break it down. So here we have a diagnosis of someone who's 33 years old, has fabulous embryos, but has had 1 miscarriage. So I always tell people, let the pregnancy teach you a lesson, and go back and think about the angel method or angel workup and look at all the things that I talk about there and see if there's a reason why you should be addressing those things before your transfer. For example, autoimmune issues, cavity issues, right? Nutrition, genetics, endocrine. So for you with your BMI at 36, let's look at everything. Your liver function, your hemoglobin A1C, your cholesterol panel, right? That will be super helpful for you before you go into another transfer. And then as far as doing an ERA or not, remember the 3 questions. What do I want? What is it going to take? And am I willing to do it? You have so many beautiful embryos based on what you described to me. Let your embryos talk to you. Look at the report and see how many you have. And then think about, okay, how many embryos will it take to have the number of kids that I want? And then sometimes I think it is helpful to look at gender too, because if you only have, let's say, 1 girl and the rest are boys, and you wanted to transfer the girl first, I highly recommend that you maybe consider ERA testing. Otherwise, if gender is totally not an issue for you and you have several embryos that have normal chromosomes, then I would say it is totally okay to skip ERA, even with a BMI of 36. I wouldn't get too excited about doing the ERA for somebody who has so many gorgeous embryos. However, I always ask the question, if we transferred and it didn't work, would you be upset that we didn't do extra testing? And if the answer is yes, I would do the extra testing. And then talk to your doctor about, have I ruled out adenomyosis for me? Or have you ruled out adenomyosis for me? And would it make sense to add letrozole to my transfer protocol, or even a month of Depo-Lupron ahead of time? And that Depo-Lupron, watch my survival, I think it's the survival video for Depo-Lupron. You have to watch it, because I can tell you that stuff is for reals, like not so fun. But at the end of the day, I think you're in great position to be successful, and I don't want you to think that your BMI is necessarily going to get in the way. Just continue to do all the healthy things that you know to do, okay? Next question is from Lindsay. Hi, Dr. Aimee. I'm 36 and have done 5 rounds of IVF due to low AMH. I only have 3 early blasts, which have been frozen from the last 5 cycles. I've been diagnosed with endometriosis, deep infiltrating on my pelvic wall and close to my ureter. Surgery was not suggested because I have no pain and because of the location. Is this the right approach with regards to my fertility? Could I also have superficial lesions that will affect embryos implanting? Can the endo also cause poor egg quality, which I seem to have? Thanks so much. I appreciate all you do for our community. Okay, Lindsay, you are a warrior. 5 rounds of IVF. That is great. So what I would do is go through the embryo diamonds algorithm that I've shared with you guys before. Talk to your doctor about the implantation rate per embryo, and just break it down. Like, what day is the embryo? What is the implantation rate? It sounds like you didn't do any genetic testing. And then ask, will these embryos help me, reach my goals and fulfill my dreams of family? And the thing is, if the answer is not yet, I think it makes sense to potentially not necessarily do more cycles, but maybe consider other options and just talk about them, right? Just say it out loud. Just talk about adoption, talk about embryo donation, talk about egg donation. Not because anyone thinks you need them. It's just nice to talk about something that's going to make you a mom and turn you from a patient into a parent. But if you were a patient of mine, this is what I would do for you. Number 1, I would strongly consider doing implantation testing first. Do the ERA and receptiva tests and allow those results to guide us as far as what we need to do next as far as surgery goes. Because we know that endometriosis can affect fallopian tubes. We know endometriosis can affect the walls of the uterus. So it might be smart, before you use your embryos, to consider a laparoscopy and a hysteroscopy at the same time. Also, given the nature of your endometriosis, you really want to get a second opinion, in my humble opinion, from an endometriosis expert. So I don't know who would be doing your surgery for you, but I love there's so many wonderful endometriosis surgeons in the Bay Area, and I love Dr. Nezat. He has the hands of God as far as I'm concerned. But and there's so many out there that are minimally invasive gynecologic surgeons like Dr. Young, Dr. Cardos. I mean, I could go on and on about how talented these surgeons are. But the answer is yes, endometriosis can affect egg quality. There's no doubt that it does. And it also decreases implantation rate. So I take endometriosis very, very seriously. So if it looks like it's really affecting the walls of your uterus, and given the number of embryos that you have, you might want to actually talk about, just say it out loud, talk about it freely, and then see how it makes you feel. Because at the end of the day, you've done 5 cycles, and I want you to be a mom to your own eggs, right? I mean, obviously, I really want you to experience pregnancy, but I think it's important to talk about, does it make sense for us to also consider a surrogate if my uterus is really affected by endometriosis? You may want to talk about that sooner than later, excuse me, and then hopefully your first transfer will work and be wildly successful. So as I'm coughing, this is a good segue into showing you guys this fabulous cup that someone got me today. It actually came as a delivery. It says, Dr. Aimee, at your cervix. And that is true. I do spend a lot of time looking at the cervix. So I'm just going to take a little swig of my coffee. and go to the next question. This question is from Alejandra. I'm 35 years old. I had a miscarriage last December. I've been trying to get pregnant ever since. I've been tracking my BBT and it starts to drop at 10 days post-ovulation. Is this normal? My progesterone measured a week after ovulation was 18.5. I have an AMH of 1.68. Is that considered low or okay? My OBGYN opinion differs from my RE. OBGYN says it's fine. RE says it's on the lower side. Thank you. Alejandra, your AMH is fine. I'm not worried about it. I'm not worried about it at all. But you know, my egg whisperer golden rule. You're 35, right? Like you hear people saying, freeze your eggs, freeze your eggs, freeze your eggs. Well, I want to tell you that you can freeze embryos too. Go back to that miscarriage and talk to your doctor about why they think it happened. What are the possible explanations and what testing do they recommend for you? Test and don't guess. And again, the 3 questions. Alejandra, what do you want? And what is it going to take? I mean, if you guys have been trying for some time and you had the miscarriage and you guys want 2 kids, we know it is so much harder to get pregnant over the age of 37 than at 35 and 36. So I would suggest, I mean, it sounds like the REI is just caring and coming from a good place and is well-intentioned. I don't like the fear-mongering tactics. And remember to always remind your doctors that your priorities should be theirs, not the other way around. So talk to them about what treatment options are available to you, what the pregnancy rates are associated with them, and how will they help you reach your goals. You know, what drives me nuts is when I see someone who, let's say, is 41 years old, they spent 3 years trying for baby number 1, and then no one, like they had told so many doctors about this and no one told them that they should take their age seriously after they deliver. And they just thought because their OBGYN, well-intentioned again, said, oh, if you just get pregnant with baby number 1, the second baby will be easy. Or even worse, oh, you had a miscarriage. That means you're not going to have any problems at all getting pregnant. All of those things are fertility myths. So I would say, Alejandra, take CoQ10, keep trying for sure, and maybe wait a few more months. If you guys aren't successful, no big deal. You have so many options. And the other thing is, if you choose not to do IVF now and you get pregnant naturally, well, guess what? 6 weeks after you deliver, you can go to that fertility doctor. I mean, you probably don't want to do it 6 weeks later, maybe 3 months later. You can freeze embryos then, okay? This next question is from Ashley. Hi, Dr. Aimee. Thank you for all you do. I wish everyone loved their job as much as you do. I know. Seriously, I don't know where I get this from. I'm 39, AMH is 1.7, endometriosis, and considering taking NAD in preparation for an egg freezing cycle. However, I see it can cause anxiety and I'm prone to this. I had a very bad reaction with methylfolate. In your opinion, is it worth to take a chance with a smaller dose of 150 or better to stay away? I'm also taking, here we go, ubiquinol 400 milligrams, acai berry, NAC, fish oil, vitamin D, and a prenatal. I was going to add lipoic acid, but read it can cause problems if you have mercury fillings. I wasn't aware of that. I need to research that. Would you add or take anything away from this regimen? Is myoinositol advised if you don't have PCOS? So myoinositol can potentially help women who have endometriosis. But when my patients are taking so much already, I don't necessarily add more stuff. But that is something that you can consider taking. As far as the NAD causing anxiety, it absolutely can make your heart feel like it's jumping out of your chest. But the good news is this. You take it, you feel that way, you stop it, it goes away. So it's not like permanent anxiety that starts, okay? So don't worry about that. So I would say maybe in the beginning, don't take 150 milligrams every day. Maybe go every other day and see how you feel. And then if you feel really good on it, then go to every day. I take it every day. Okay, this is from Jennifer. Thank you for what you do. My husband and I are considering next steps in our fertility journey. We've done 4 rounds of IVF and have 2 frozen embryos. Round 1, age 35, AMH 0.37, 6 eggs retrieved, 1 embryo to blastocyst. My FSH is 12, no normals. Round 2, age 36, 12 eggs, 2 embryos, 1 came back normal. At age 36, 7 eggs, 2 embryos, 1 came back normal. At age 37, now my AMH is 0.17, FSH is 19.5, 4 eggs, 2 embryos, none came back normal. We want 2 kids and wanted another embryo in case of failed implantation or miscarriage. We've tried naturally for 6 months. My HSG looked good. However, we haven't gotten pregnant. We're debating an FET next month, saline sonogram first, or trying 1 more round of IVF with implantation. I turned 38 in 2 months. We switched to non-toxic products in the last 6 months. With my AMH and FSH so bad, I worry another round of IVF won't work now or in the future. Okay, so when I look at the trends, it looks like things are basically changing and not that much. I mean, if you think about it, when you were 35, you did not have an embryo that had normal chromosomes. And now at 37, you didn't. But in between, you had one each time. So if you look at the number of eggs that you had, obviously the egg count is fluctuating. But my suggestion, and what you're doing makes perfect sense, is that if you have it in you to do one more cycle, do it. But your AMH suggests that the egg count will probably be between 1 to 3. So I would think about things this way. If I didn't do another cycle and this next transfer didn't work, would I be really upset and wish I had? And if the answer is yes, I have it in me to do another cycle and I would be really upset, then let it go and go do it. But if you're like, you know what, this has really taken a big toll on me, physically, financially, emotionally, I don't know that I can emotionally go through another IVF cycle that resulted in no embryos, then please don't do it. Again, this is the time to talk about other options. This is the time to see how you and your partner, are you on the same page about what you would do if, let's say, one of the embryos did implant and one didn't. Just talk it out. Talk with a therapist. That's what I would tell you if you were one of my patients. So other suggestions, you've probably heard of this so many times before about implantation testing. It sounds like you've already evaluated the cavity, look at preconception labs, and talk about everything with your doctor and ask the question, what would you do if this next transfer didn't work? Because whatever that is, I want all the testing and I want to do it up front. So I hope that helps. So Leslie is asking, hi, Dr. Aimee, thank you for all you do. I'm 35 years old and have never been pregnant. My protocol for my one and only egg retrieval consisted of birth control, Lupron, Menopur 150, 300 of Follistim. My follicles grew slowly, but my last ultrasound on cycle day 12, I had 9 follicles on the right, measuring 14 to 21 millimeters and 7 on the left, 11 to 19. They predicted 12 mature eggs for retrieval. We triggered 10,000 units of pregnal. I had my egg retrieval and 10 eggs were retrieved and only 3 were mature. Wow. So what they said is eggs could not be retrieved from all my follicles. All 3 mature eggs fertilized with ICSI, but 1 resulted in an abnormal embryo. If we do another round of IVF, what would you suggest changing with my protocol to yield a greater number of mature eggs? Okay, Leslie, I'm going to dissect this. So thing 1, when you don't have as many mature eggs as you expect, you have to ask, was there a trigger shot failure? When I look at what you took 10,000 units of HCG, and that's a great amount. So I don't think it's a result of not having enough HCG. The other thing I asked is, did you ovulate? And it sounds like you didn't, because if you think about it, you had 9 follicles on one side and 7 on the other side. That's 16 follicles. So getting 10 out of 16, especially when your doctor was expecting just a few more mature, I'm not sure that's the issue either. So what this could be is something that's really complex, and it could be related to something genetic that's causing your egg quality to be lower than what they think. But I'm pretty stubborn. I can tell you something that I wouldn't just go out with this cycle. I would certainly do another, just like you're planning on doing, and then cut out the birth control pills. I swear, some people are more sensitive to them than others. And I've seen situations where you remove the birth control pills and then you get more mature eggs. So that's something to ask your doctor and see what they think about that. And I hope that strategy helps. And a couple other things I'll just add to. One thing is maybe consider, adding HGH, the supplements that I always talk about, CoQ10, pterostilbene, NAD. And then the other thing is maybe take out the Lupron from your protocol. And the reason is this way you can also use Lupron as part of your trigger shot. So you can use Lupron, HCG, and an antagonist like ganirelix or cetrotide. So see if your doctor is thinking about switching the protocol and ask why or why not, and then get the answers that you feel comfortable with before your next IVF cycle. But I still think at 35 years old, there's still at least a 35% chance that you will be successful with your next IVF cycle. So don't give up and keep doing everything that you're doing. This next question is from Emily. I had an unplanned C-section with my first IVF baby 18 months ago. I don't have any embryos left on ice, so I'm starting IVF and testing again. Are there any special considerations for starting IVF after a C-section, like increased HSG abnormalities, poor egg quality or quantity, etc.? Great question, Emily. So this is the thing. Your ovarian reserve might just be a little bit lower because it's 18 months later. The likelihood of a C-section resulting in blocked tubes, super small, super small. It's very, very rare that a C-section would cause tubal damage. Unless, of course, you had an abruption, an infection, a stat C-section where they couldn't sterilize anything as fast as well as they normally would. Otherwise, the likelihood of damage to any of your organs, super small. There is a condition called CSD, cesarean scar defect, again, very rare, where you have a window that's wide open, well, not necessarily wide open, it just depends on the defect, that might affect your ability to get pregnant and have a healthy implantation. But again, super, super rare. So I wouldn't sweat it. I would just take your CoQ10, measure all your levels, your FSH, estradiol, AMH, and get fully prepared and get the sperm into a sperm fitness boot camp. You can go online and sign up for one at ballsmethod.com. I'm just kidding. There's no sperm boot camp, but there should be. There should be some like virtual sperm camp. A sperm camp for men. This next question is from Dana. Hi, Aimee. My question is about spotting after the IVF transfer. After my first transfer, I had spotting 3 days post 5-day transfer. All my beta tests were good, but then at 5 weeks, 6 days, I had a miscarriage. I'm sorry, Dana. I've just had my second transfer. I'm currently 4 days post 5-day transfer, and my spotting has started again. Is this a sign I'll have a miscarriage again? I was really hoping for no spotting this time. Okay, this is the thing. That could be implantation testing. Every pregnancy is different. Every experience is different. Every HCG level at the start of the pregnancy is going to be different. So I totally get how triggering seeing the spotting again can be. And what I tell my patients is, look, your spotting is so common and it can happen in perfectly healthy pregnancies. But I want you to come in as soon as I can possibly test HCG hormone levels so I can reassure you. At the same time, I would ask you if you were a patient of mine, do you want to come in for extra hormone testing just so we can see the levels? Let's look at your estrogen and progesterone and make sure there isn't anything we can be doing differently right now to help you. And then at the end of the day, like I said, it could be totally normal. And that's the hardest part of being pregnant. It's just not knowing what's going to happen. I wish that there was some sort of test, like an early pregnancy factor or blood test that we can do to detect implantation and see if something was working well or not. In fact, I wish I could send in like a little camera in with each embryo to follow that embryo around and see what was happening. I mean, you've heard of embryo scopes. There should be like pregnancy scope, right? I mean, you can swallow a pill and look at your colon. Wouldn't that be cool if you could swallow something and look at your baby inside your uterus and know what was going on and see things ahead of time to prevent things possibly from happening that could be going wrong? I think I'm onto something, guys. I mean, if freaking Elon Musk can send things up to the moon, why can't we do this already? So this next question is from Megan. Hi, Dr. Aimee. I got my eggs frozen at 36. And she shares something pretty tragic. And she shares that it was after her fiance passed away. I got 13 eggs. AMH was 5.7. FSH was 5. It's now a year later, and I'm still worried about my chances. I really want 2 kids someday. Should I freeze more eggs when I can? FYI, my mother and grandmother both went through menopause at 42. Thank you for your time and advice. Okay, Megan, the answer is yes, I would totally freeze eggs. And this is the other thing. I would consider making embryos before you've run out of healthy eggs. Why? Because I don't want you to have any fertility regret. I want you to know what you have frozen. So sometimes in a case like yours, I would say, let's find out more about your eggs and maybe fertilize some with donor sperm if that's acceptable to you. And if you would consider being a solo mama by choice in the next 5 years, it might make sense with your next egg retrieval to maybe freeze 10, fertilize 3, and let's see what happens. Because then at that point, if you learn that, once you fertilize the eggs, they stop growing, then you might want to consider doing even another cycle of egg freezing before you've run out of healthy eggs. So one of the mistakes, and I call them my egg whisperer, egg freezing rules. I got to make a whole set of rules for people who are freezing their eggs. And one of them is, like I said, to consider freezing more eggs while you still have eggs if you're not going to make embryos. And then if making embryos is acceptable to you, make embryos before you've run out of healthy eggs. You have the opportunity to make even more. Okay, I hope that all makes sense. And then I'll add on, take your CoQ10. This next question is from Angie. Hi, Dr. Aimee. Our fertility diagnosis is PCOS and male factor morphology 0 to 1%. I'm 33, just did my first egg retrieval, 26 retrieved, 17 mature, 10 fertilized. That's really good. Waiting to hear back on my day 5-6 update. We did 75 Menopure and in the morning and 200 gonal at night. We reduced the gonal for the last 2 days. Instead of doing the doodle trigger, oh my God, I like that name so much better. Dual trigger. The doctor said only take the Lupron, no HCG. My estrogen was very high, they said. On trigger day, I had 3 follicles over 21 and over 20 follicles over 12. So here are my questions. Did not taking the HCG hurt the maturity rate? What could cause such low fertilization? So let me just break down the first two questions you asked. So the thing is that, did HCG hurt the maturity rate? 17 mature is pretty darn awesome. It really, 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 really is. So I'm not sweating that at all. The thing is this, your doctor didn't want to hurt you. Like, they wanted to keep you safe. They don't want you to go in the emergency room. They don't want to be aspirating fluid out of your abdomen. So anything over even 12 is like really awesome. But when you get over 15, you are at higher risk of having ovarian hyperstimulation syndrome. So they totally did the right thing. I totally support what they did. So the next question you ask is, what could cause such low fertilization? We did ICSI. So remember, guys, diagnosis before treatment. So you already shared that the morphology was really, really low. So if the morphology is low, it means the genetic, what am I trying to say? There might be something genetic going on with the sperm, and it might cause a lower fertilization rate. So don't sweat it. You crossed that hurdle. You crossed that fertilization bridge. You got fertilized eggs. So I'm super excited about that for you. And having 10 embryos at 33 is pretty incredible. So I imagine that things are going to go really well for you. So you also asked me, I'm expecting 2 to 4 blasts and 1 to 2 PGTA embryos at best from this cycle. So I would say, I think you're actually going to probably get 2 to 4 normal blasts. I hope to be right. Let's see if I'm right. So here are the questions that you've asked me as well. What other changes would you recommend? Calcium activation, triggering earlier or later, adding back in the HCG trigger. Thank you so much. So I would say maybe think about sperm DNA fragmentation. Go back to the balls method. Just kind of go back to basics and see if there's anything in your control that you can improve before your next cycle, if you need to do one. Talk to your doctor about Pixie, Zymont, and other procedures that might improve fertilization next time. See if calcium activation is an option at your clinic. Not every clinic believes in it, and not every case is indicated, or not every case needs it. Having 10 fertilized out of 17, I promise you, is not terrible. It is, what's 17 divided by 2? Quick, Amy, quick. It is over 50%. But at the end of the day, the morphology is really what probably was driving that for you. So see what you can do. Get out of the hot tub. No more scotch drinking. No more bubble baths, please. And I have a feeling that everything's going to go just fine for you, Angie. This next question is from Rosie. Hi, Dr. Aimee. Thank you for being the perfect combo of extremely useful. I like to be called that. You're extremely useful. That sounds like a good compliment. And super funny. I'm not sure how funny I am, Rosie, but I'm trying. I'm taking a comedy course. I'm not. I don't have time for that. My husband's pre-wash sperm report for our recent IUI came back at 60% motility, 138 million count. I think he's bragging. I mean, that's pretty good. And 1 to 2 forward progression. So this is the question. Does this mean his sperm will always need to be washed and that sex at home is just not going to be successful? No, not at all. I mean, I feel like if you have a pre-wash sperm report for your recent IUI and it's that fabulous, sex at home could totally be successful. It's way more romantic than my office. Certainly IUI can be a great option for people who fight around ovulation. If there are issues with erections, if let's say there's like some timing issues with where you guys are with work and what's going on with your schedules, and take it out of the bedroom. But for the most part, with those kinds of counts, 60% motility, 138 million, and 2 forward progression, I think we're doing just fine. But take a look at the morphology and the shape of the sperm, which is the shape of the sperm, and then ask your doctor that same question, because they'll see all the parameters and be able to give you some good advice. This next question is from Lauren. Love you, Dr. Aimee. Hi, Lauren. So wish you were on the East Coast. Me too. I really wish I could be there, actually. I have family in Boston. I wish I could see them, and it's just too bad that I can't see them right now. I'm trying to get my auntie to come out here, but no such luck, or I should say auntie. Okay, so I had a laparoscopy hysteroscopy in July to remove an endometrioma on my left ovary. I was diagnosed with stage 3 endometriosis in a right block tube. In my first IVF cycle, 1.5 months after surgery, I had poor response and my cycle was canceled after 10 days of stim. Oh my God, that is a long time to be on stim to decide to cancel it. I'm sorry, Lauren. That's hard. Turned around, strong work, you're strong and resilient, and did a second IVF cycle, new protocol, and we ended up with, what's up? 4 PGS normal embryos. Ha! I love it when that happens. Your doctor was probably high-fiving you. Up high five, down low, too slow. Okay, getting ready to meet with my doctor to discuss next steps, and I'm not sure what to ask. A transfer always felt out of reach. I know endo makes it more difficult, and I want to do whatever I can to give this our best shot. What questions should I ask or topics should I discuss with my doctor before our first transfer? Awesome. I'd love answering this question. Number 1, embryo diamonds. Print out the list from embryodiamonds.com and go in there and be like, what day are my embryos? What's the implantation rate? Which ones are mosaic, if any? Ask those questions up front. Then say, have you ruled out adenomyosis? Have you ruled out a hydrosalpinx? I know my fallopian tube is blocked. Would that increase my risk of having implantation failure in ectopic pregnancy? Should we do another laparoscopy? Why or why not? And should I do implantation testing? If you were a patient of mine, this is what I would do. ERA receptiva, maybe repeat HSG after your surgery. Consider removing that fallopian tube, cleaning up the house before the most important guest goes in, and then transferring. If the endometriosis seems really bad, for example, if you have really bad symptoms and you don't want to do surgery, that's okay too. Consider doing a month perhaps of Depo-Lupron with Femara daily before your first transfer. But it sounds like everything will hopefully be fine. And if you want, it may not be a bad idea, especially with the severity of your endo, to even consider doing another cycle now before you do all of that stuff. I don't want to take your youth for granted. I would say if that's something that you feel like you have it in you to do again, maybe get more embryos before you start all that stuff to prepare for transfer. Okay, Lauren, I wish you all the best. Okay, this next question is from Colleen. Hi, Dr. Aimee. My husband and I are both 31 years old. He doesn't have any sperm issues, but I have stage 4 endometriosis and my AMH is 6. We just did our first round of IVF and I got 33 eggs, 23 mature, 10 fertilized via ICSI, and 5 made it to day 7 blasts. Does the number of mature eggs seem low to you given my high AMH? Does ICSI lower the number of fertilized eggs compared to non-ICSI? Would you expect to get only 5 transferable embryos given an AMH of 6? Okay, Colleen, here's the thing. It doesn't look like you did genetic testing, so it's hard for me to know exactly totally what's going on, but I'm just going to run down the list of things that I would be thinking if you were my patient. Number 1, what the heckity heck? Only 10 fertilized out of 23 mature? What happened? Talk to the embryologist about how your eggs looked. Were they sparkling? Did they look dark and grainy? Is this related to egg quality or sperm quality? How is the sperm sparkling? I just see patients all over the country being like, dear doctor, did my husband's sperm sparkle? They'd be like, what? Okay, but literally, like, you can just use those words and see what they say as a joke, because it is kind of funny. But anyways, it's kind of like saying butt jokes and fart jokes, sparkle jokes, just not jokes, but saying sparkle just makes me happy. But I would ask about the egg quality and the sperm quality on the day of the egg retrieval. Ask about any advanced genetic testing you should be doing. Does it make sense to do sperm DNA fragmentation testing? Does it make sense to do chromosome analysis on both of you? I'm actually not so worried, and not that I'm worried. I feel like you still have a great chance of pregnancy because of your young age. It's not so much the number of fertilized that has me thinking about you. It's actually the number of blastocysts and when they reach the stage that they reach. How fast were they growing? So your embryos reach the blastocyst stage day 7. So go back to the embryo diamonds and ask your doctor, what day were my embryos frozen? It looks like it was day 7. And what's the implantation rate in your lab? Because that will give you as much information as you need, or all the information you need to decide what to do next. Because it sounds like maybe doing another cycle could make sense. Because if you haven't done the genetic test that I just brought up with you, it might make sense to do another cycle if you learn something that maybe, I don't want to say would have been helpful, but learn something that you can apply to your next cycle or apply to the decision making that you're going to be making. I used the word making twice in a sentence. I'm not sure that that's good public speaking here, but that's okay. So this next question is from Vivian. Vivian asks, let's see here. Love you. Thank you, Vivian. I love you too. I'm 37. At 33, I had a miscarriage. It was unplanned. Got pregnant at 34, only after 2 cycles of trying. Healthy baby pregnancy. Then we started trying to conceive, number 2 shortly after, and nothing. And it's been 2 years, and now I'm 37. I'm starting infertility treatment. All tests diagnosed as unexplained. And you guys know me. I roll please. Like, really? There's no such thing as unexplained. I began IVF October 9th. Yesterday got the news that only 6 eggs were retrieved, and then today the doctor called with the bad news. None of my eggs normally fertilized. They all fertilized, but abnormally. Doctor says it's rare that this happens to all eggs. What are your thoughts? My levels are normal. Semen analysis is normal. We want to try another round, but after that, I think it's time to close this chapter. Okay, so if you were a patient of mine, I would say your diagnosis is most likely age-related infertility. However, since we know you already had a pregnancy at 34, I know you had good eggs at one point. I can't imagine all of a sudden all your good eggs would disappear. So this is what I would go through if you were a patient of mine. So I would say your partner, it sounds like he hasn't had previous pregnancies. So let's look at that really carefully and closely. In fact, I would do chromosome analysis on both of you to see if somehow that was related to what happened. Again, look at the sperm DNA fragmentation. See if that is abnormal. And if it is, do what you can before you do another cycle to fix it. Talk to your doctor about how to support egg quality and sperm quality. Egg quality supplements like CoQ10, NAD, pterostilbene, spill the beans. And then for him, what can he do? He can still do all the same stuff as you. He can take NAD too. He can take perhaps something like Conception XR, and again, same code, Tushy, all caps, from Theralogics to support his sperm health if it's indicated or needed. So your doctor's right. It's really rare to have 100% abnormal fertilization, but Zymot, Pixie, HGH priming, these are all tools that can potentially help with the egg quality, and I'm talking about the HGH. And from the sperm standpoint, the Zymot and or Pixie could potentially help your doctor pick the most fabulous sparkling sperm to put into each of the eggs. So I'm really hoping that your next fertilization is fabulous and your eggs fertilized normally. And I want you to visualize that and think about that. And then also talk about what would you do if this next cycle resulted in the exact same thing. Because if it's too much for you, if you're like, you know what, I don't know that I can handle that again, don't put yourself through it. There's so many other ways to grow your family with your husband. But if you feel like I still have one more cycle in me, I still think it's worth it to try again. Again, I am totally biased, but I do think when you're working with human biology, there's so much cycle to cycle variation, and I never know what I never know what I'm going to get. Sometimes I can get one cycle, no blast, next cycle, 5 blasts, and 3 or 4 normal. And it's like, what? Like, why did I have to go through that first cycle to get that the second cycle? It is so annoying. So, Vivian, keep trying. That's what I would do if you were a patient of mine and what I would recommend. So this next question is from Kay, and Kay is asking us about my opinion about IVIG versus prednisone treatment for autoimmune infertility. Our trying to conceive journey started in August 2018 after I stopped birth control, thinking I would get pregnant naturally. February 2019, no big fat positive, consulted with an RE, AMH 4.76, tubes cleared, did several medicated cycles with and without IUI, but still nothing. Moved on to an immunology workup in February 2020, found that I had antithyroid antibodies and thyroglobulin antibodies, TSH, free T4, totally normal. My RE told me to go see an immunologist who gave me the option to take prednisone until I get my period and repeat it up to 3 months. That's a lot of prednisone. She also mentioned IVIG, but I had opted to try prednisone first. So my questions are, did I make the right choice? I'm 38 years old, but my RE never suggested embryo freezing. She didn't ask me how many kids we'd like to have. We'd be more than happy with 1, but open to having up to 3. Kay, run to a fertility doctor that's going to believe in your fertility and start freezing your embryos and get it done yesterday. I mean, not really yesterday. The likelihood that everything that you're going through is a diagnosis of autoimmune infertility, Let me tell you why. AMH of 4, so autoimmune thyroiditis, is the leading cause of premature ovarian failure. You don't have that. You haven't run out of your eggs. You have perfectly healthy eggs, in my humble opinion. I mean, obviously we don't know that for sure until you actually go through your embryo freezing. But I really feel like with everything that you've been through, starting in August of 2018, you're now 2 years into it. I would strongly suggest that you go through the Tushy method, really outline the diagnosis very, very well, repeat your AMH, do a follicle count, and talk to a doctor about IVF. And then, guess what? Before you transfer, look at your thyroid antibodies and make sure they're going down. I wouldn't do prednisone. I wouldn't do IVIG. I would do naltrexone. Naltrexone is like magic for women who have antithyroid antibodies. It brings them down. Don't ask me how it does that. I have no idea. Like literally, like I've researched it, I've looked on PubMed, and the mechanism of how it does that, who knows? But it does that. 25 milligrams, so it's 50 milligram tablets, half per day. That's what I prescribe my patients. And then you can also take low-dose naltrexone. You can get it compounded, let's say 3.5 to 4.5 milligrams per day as well. But in the beginning, I would see if you can tolerate 25 milligrams and then go from there. But it does help. Again, don't know how. I learned it from a functional medicine doctor, and I've been using it for the past couple of years. And the stuff that I'm seeing is like blows my mind, as far as like not just what I'm seeing with the antithyroid antibodies coming down, but what I'm also seeing in women who have premature ovarian failure caused by an autoimmune disease. I'm seeing that their eggs are starting to grow, their FSH level is going up. So I would say go to the RE, find someone that's going to ask you the 3 questions, and start doing what you need before too long. Okay? I'm excited for you, Kay. This next question is from B. B says, I was diagnosed with unexplained infertility and been trying to get pregnant for 19 months. 32 years old, my AMH is 1.2 and all normal tests per my RE. Healthy BMI, I weightlift and spin 4 to 5 times per week. My husband's sperm sparkles and is excellent. I've done 4 IUIs, all failed, and we will likely be pursuing IVF. I've gotten a pretty intense spreadsheet where I track all my test results and recently found a trend that in every phase of my cycle, my estradiol is off the charts high. This is the case whether I'm on Clomid, Letrozole, or no medication at all. For reference, last month, my cycle day 12 estradiol was 1,061. Is this a concern? This is the only thing that jumps out at me, and no medical provider has brought it up. Any guidance is welcomed. You know, B, your husband's sperm sparkles. It sounds like your eggs are sparkling too. Having a high estrogen after ovulation or around ovulation time, which is around cycle day 12, is super normal, especially if you're taking drugs like Clomid. When you're taking Clomid, you're probably ovulating 3 or 4 eggs, I imagine, just because you're young and your AMH is pretty good. So I would say if you were a patient of mine with your AMH of 32 and, age 32, AMH of 1.2, I would say it totally makes sense after trying for 19 months to go to IVF now. So talk to your doctor about what they're going to do for your IVF protocol, why they're choosing what they're choosing, and what your IVF pyramid is going to look like. IVF pyramid, talk to them about the number of follicles they see, the number of mature eggs they expect, the number of fertilized eggs they expect, and ultimately the number of blastocysts, and ask them why they would choose genetic testing for you, why or why not. And make sure you've done enough genetic screening before your IVF cycle, like the carrier screen and the chromosome analysis. So I think the chromosome analysis is important, especially for people who are going to skip genetic screening of their embryos, so that you don't look back and be like, why didn't I know this? A simple test could have told me to test my embryos, and it could have revealed what's going on with you guys too. So I wish you all the best, B. Don't forget to take your CoQ10. Okay, this next question is from Steph. Hi, Dr. Aimee. Thank you for all your insights for these Q&As. They're so helpful. I've just turned 36. I have a low AMH of 0.2, AFC 3 to 5, and I've had 5 failed IVF cycles. Currently in my 6th, and we're doing duostim. My only egg retrieval, we managed to get 3 mature eggs and only 1 fertilized, and it resulted in a chemical pregnancy. Chemical pregnancies are my enemy. My question is, at 36, lower chance of multiple embryos, do you think it's worth PGS testing? Is there a chance we would risk viable embryos being discarded? This is the thing. Remember, Tushy, the why, make sure you screen out all the genetic stuff. Otherwise, there's really no reason that you have to do genetic testing. However, I would talk to your doctor. Every lab is different. Everyone's strengths are different. You know, I'm so lucky. 5% of embryologists are top notch. And they're almost all like in the Bay Area. So we're kind of spoiled here in the Bay Area. I don't worry. I don't go to sleep at night worried that someone has damaged my patient's embryos. But I know it can happen. So if your doctor is saying, I don't think you should test your embryos because they could get damaged, please trust them. Don't do it there. Don't test your embryos. And I would say the other benefit of testing is, you don't necessarily have to test. You can bank embryos and not test them, is so you know what is waiting for you in the future. So if you're a patient of mine at 36, I would say, listen, you've already done 5 cycles. You're going into your 6th. Let's talk about other options to help you be a mom, because you're so young. I don't want you to keep, I love you, but I don't want to keep seeing you. I want you to start sending me baby pictures. But I think that that's a very personal decision too. Some people are very motivated to keep cycling for their own personal reasons, and your priorities have to be your doctor's priorities. But I'm thinking that for you, I don't know. I think at this point, it might be, I can't really say. I don't have a strong gut feel, Steph, as to whether you should be PGS testing or not. I feel like after the number of cycles that you've done without having a blastocyst yet, I think the reality is that the likelihood of us having a strong enough blastocyst that your doctor's fired up about biopsying is probably pretty low. But I think you can definitely review that with your doctor. And you never know. Every cycle is going to be different. And so hopefully with a new set of eyes, if you're getting a second opinion, that new set of eyes will reveal something amazing and helpful. Okay, this question is from Amanda. I love your show and positivity. You give us all hope. I'm 39. My husband has low morphology, has 2 children from a previous relationship. They are 21 and 9. I went through 3 medicated IUIs and got pregnant on the 3rd. I went in for my 7-week ultrasound and the doctor said it looks like a 5-week scan. Oh, I hate that. I go back in a week to see if there's a change. I'm trying to stay positive. If I miscarry, do you suggest I try the IUI again or move on? Do you have any other advice for someone my age? Thank you for all your listeners. Okay, Amanda, at 39, you've already had a miscarriage. I would say go right to IVF. We don't have time to spare. You don't want to waste your youth on more miscarriages. Your eggs, from my standpoint, are going to be young and healthy, but we know it's so hard to get pregnant at 39. So if you have it in you to do IVF, and if that's something that's acceptable to you, I would say just go right to IVF and start preparing for it. Prepare your eggs, do all the good stuff that we talk about, like being as healthy as possible, and make sure your husband stays out of the hot tub and sauna and stops drinking his scotch. But I hope ultimately that you don't miscarry. But if you're a patient of mine and the pregnancy is well-timed, we know exactly how pregnant you are, I would talk to you about your options, and I would suggest that perhaps consider medical management of the miscarriage versus surgical management, and of course versus just waiting for it to happen on its own. And then if you're a patient of mine, I would say come back in 2 weeks if you want to wait on its own, and if it still hasn't passed, we would go through all your options again and see what you want. Because the sooner that you're not pregnant, if this is indeed an abnormal pregnancy, that means to us the sooner we can have a plan and plan for our next steps. So it might take 6 to 8 weeks for your next period to start after a miscarriage. And so this is the perfect time for you to start reviewing the possibilities, reviewing the options, talking to a therapist, talk to your husband, and see what you guys want to do next. Okay, guys, I did it. I went through all the questions for tonight. Yay me. And now I'm just going to go through all your questions real quick because my butt is starting to fall asleep from being here for so long, and I love being here. And so I just want to make sure I've answered all your questions. So you guys have posted such sweet comments. Okay, so someone's asking, is there an age that's too old to donate eggs? The answer is if you're doing for a family member and you still have eggs and everyone knows what the chances are, I don't think it's too old. However, typically, if you're over the age of 32 and don't have a high enough egg count, we typically would encourage you not to freeze eggs and to freeze eggs for you. Next question is, any tips for FET success if you've had good embryos but thin lining? Could ERA result be not enough? And the answer is, if your lining is thin, I would say wait for it to get thick, especially if you have these precious embryos, and work on that part. Look at your, nutrition, talk to an acupuncturist. Bring in everybody. Take supplements like vitamin E, L-arginine, aspirin. Think through whether you have Asherman syndrome, or, which is basically scar tissue in your uterus that could be causing the thin lining, and talk to your doctor about other protocols and medications that can help. Next question, thoughts on fresh versus frozen donor eggs to make embryos. Go to my blog, draimee.org. My last post is all about frozen eggs, and I have lots of blog articles on fresh eggs too. I don't remember who I did a talk with, but donor eggs are great. I work with 5 egg banks like Simplify, Fairfax, the World Egg Bank, Donor Egg Bank USA, and Ovation. All have done fabulous jobs for me. Do you think COVID will start to cancel some of our cycles again? Have doctor visits shown to increase community spread of COVID? No, I'm so lucky to say that. And I know that there are other clinics that haven't been as lucky, but we're very strict here. No spouse for you, no loved one for you. I know, that's really mean to hear, but the reality is I have to minimize the number of people in my office. God forbid someone comes in and we didn't know that they had the sniffles, or they didn't tell us because we ask everybody, and then all of a sudden all my staff are out. Ultimately, I tell my patients, I will keep working unless there's something wrong with me, right? So I have to keep myself safe. So I don't see that every single day we're taking it one day at a time. Dr. A, you're an angel. Thank you. I'm 35 and retrieval left after 5 embryos untested. My doctor wants to transfer 2. One good to fair. Is that a good idea? I don't want twins. Easy. If you don't want twins, just transfer 1. Done. Done. Next question. I was angry today, really angry with my husband. I started to throw things. I was talking to someone about that earlier, throwing things, and this is my 3rd day after transfer. Does that affect my embryo implantation? Okay, so Storm Brain Studio, if you are so angry that you're throwing things, that's okay. Recognize the anger and ask where it's coming from, what's making you angry, but Don't throw things at your husband, okay? I know you said you're not throwing things at him, but I would see if you can immediately go to a mindfulness practice that will stop you from throwing things, right? So Josephine Atluri, Atluri, go to her Instagram page. I'm actually going to be on her podcast soon. She's phenomenal. And find a mindfulness practice that works for you. A happy place, squeeze your buns, a mantra, wear a bracelet, something that you can just read and remind yourself that everything's going to be okay. Yeah, that's what I would tell you if you were a patient of mine. And you can throw things, but just don't throw them at your husband. I'm sure he's a doll, as you are too. Okay, Joy says, hi, Dr. Aimee. When you send the IVF patients, when do you send patients to an OB? And the answer is around 10 weeks of pregnancy. Carrie says, hi, Dr. Aimee. I'm in a natural FET and I have a UTI. My doctor prescribed antibiotics, but I'm concerned that they will adversely impact things. The answer is take your antibiotics. You don't want a kidney infection, especially when you're pregnant. Next questions. I'm 43, just had surgery for fibroids. I have to wait 6 months to start trying for kids. I don't want to waste my eggs that I ovulate each month, and I don't want stimulation meds for IVF. Okay, so that's the thing. If you're 43 and you want kids and you just had surgery for fibroids, you have to go through your questions. Like, what do I want? Well, I want kids, and it sounds like you want kids potentially with your own eggs. But if you wait, you might not be able to get that because of your age, and that's totally normal. And if you don't want to do IVF, I think it makes sense to talk about other ways to have babies. Just be realistic, practical, pragmatic, and talk to your doctor about other options, like, for example, embryo donation and also adoption. Next question is from Marianne. What's the optimal cycle date to have a Sono and endometrial biopsy done? It just depends on what you're doing the endometrial biopsy for. So ask your doctor, why are you doing the biopsy? Allie is saying, hi, Dr. Aimee. Does it make sense to have both an HSG and a hysterosonogram? The answer is yes. So sometimes with an HSG, you can see the fallopian tubes, but you can't really see the cavity really well. So sometimes I do bring patients back in for a follow-up hysterosonogram, and sometimes they see things on an HSG that I never saw before. So I'm like, I think I need to do a visit in my office and do a hysterosonogram. So the answer is sometimes it does make sense. Joy said, hi, Dr. Aimee. Why may some doctors check estradiol after transfer and others don't? And the answer is that estradiols don't usually change. When you're in a medicated cycle, you're taking estrogen, you check estrogen before the transfer, and the levels don't go down. So I don't check estrogen after a transfer. It medically doesn't change anything they would or would not do. Next question is 43 years old, AMH is 5, had fibroid surgery, have to wait 6 months. Can an RE retrieve eggs naturally each month? So I have 6 eggs or embryos. The answer is absolutely. You can just go 1 egg at a time, but this is the deal. Each egg at 43 has about maybe a 5% chance of being genetically normal. So the likelihood of going through 6 egg retrievals like that, not super high chances. However, if you can recruit a higher number of eggs, you have a much higher chance of getting one that's normal. Question from Mel, what are the chances of PGS normal blasts? I have 2 to be tested at 4AA and 4AB. I'm 34 years old. So the likelihood of PGS normal with not just the quality, but at your age is probably around 40% or so. So hopefully I am right about that, but you will hopefully have 2 normals out of your 2. This is from Allie. Dr. Aimee, my husband's free T is 9.7. His urologist doesn't think he needs Clomid. His total nodal count has varied from 6 to 60, but done at different labs. Should we change urologist? Well, I would say that if you've done advanced testing, like a sperm DNA fragmentation test, and it's totally normal, he doesn't have a varicocele, his sex drive is just on par, then maybe not Clomid. But if you just feel like you want a little something, Clomid has a lot of side effects. So maybe consider Arimidex instead and get a second opinion and then see what you think about that opinion. So I am going to have to end it here, you guys. I love you guys. And guess what? I'm going to be back. You know I will. I'll be right back here, probably in my blue dress or my red dress or my blue dress or my red dress. I do only have 2 dresses here. So I see patients in scrubs all day long, and then when it's time to do this, I put on a dress, and then I take it off, and then I go home. So that's what I'm going to do now. I love you guys so much. Thank you for sparkling. Thank you for being here and doing what drives me to work as hard as I do, and that is to believe in love. That is why we are all here. Every single one of us is watching this show because you want to bring the most amazing love into your life, into your homes, into your hearts. So for all of you that are hurting, I hear you, I see you, and I'm fighting for you. And I know you have a huge community around you that also supports you. So I hope you never feel alone, that you can reach out to a therapist if you need help. You can, join one of my IVF classes, eggwhispererschool.com, and we hang out and we party. My next class is on Monday, so I hope you guys will join me, and I hope you guys will have an awesome night, and I look forward to seeing you guys real soon right back here. See you guys later. Good luck, everybody.